Welcome to our video on preparation and methods of pregnancy termination. Let's get started. We will be discussing the relevant background information of pregnancy termination, the steps taken in preparing for pregnancy termination, and the methods of pregnancy termination. Now, in the United States, elective pregnancy termination is generally available up to 24 weeks of gestation, which is considered the age of viability. That being said, the specific laws vary state by state. Common reasons for seeking elective termination of pregnancy in the U.S. include financial hardships, disruption of work or education, and concerns over single parenting. Okay, with that background, let's talk about how you prepare for pregnancy termination. Now, there are several important steps that must be taken when preparing for this. First, clinicians should determine the gestational age of the pregnancy, and you can actually estimate that using the first day of the last menstrual period or using ultrasound. For example, using ultrasound, you can measure the crown to rump length. Okay, so once you've determined the gestational age, next, when appropriate, clinicians should offer screening for STIs, such as chlamydia, and also give RhoGAM shots to all Rh negative women. And that's to prevent the patient from making antibodies against Rh positive blood. Because when performing a pregnancy termination, it's highly likely that the fetal blood will come in contact with maternal blood. And last, clinicians should offer appropriate counseling and ensure that the patient at hand has appropriate social and emotional support through this process. Now, here's an image depicting an ultrasound measurement of the so-called crown to rump length of the fetus. And again, that's to help determine the gestational age. Now, by means of orientation, here's the fetus residing within the uterine cavity, and here's the crown or head of the fetus, and here's the rump or the hind part of the fetus. Now, in this particular case, the measurement was about 1.67 centimeters, which corresponds to a gestational age of about 8 weeks and 1 day. Now, notably, the crown to rump measurement is considered one of the most accurate ways of determining the age of a pregnancy. Now let's move on to the methods of pregnancy termination. In the first trimester, which means up to 12 weeks of gestation, clinicians may offer dilation and curettage, or DNC. They can also offer manual vacuum aspiration or a medical abortion, in other words, pharmacological. But in the second trimester, so between 12 and 24 weeks of gestation, available options are either dilation and evacuation or inducing labor. So let's dive into both of those in more detail, starting with DNC. Now, dilation and curettage, or DNC for short, or suction curettage, is a procedure that can be performed between 6 and 14 weeks of gestation. And it's actually considered to be the safest method of terminating a first trimester pregnancy. And the basic steps of the procedure are as follows. Patients are first given prophylactic antibiotics, such as ceftriaxone or doxycycline, and that's to minimize the risk of a peri-procedural infection. And once the procedure begins, the clinician dilates the cervix, extracts the products of conception with a suction cannula, and then performs sharp curettage to ensure a complete termination of pregnancy. Now, here's a figure depicting the basic premise of DNC. Now, by means of orientation, here's the bladder and the urethral opening, and the vaginal opening, the cervix, and we can see the uterus and the rectum. Now, as mentioned on the previous slides, various tools are placed in the vagina and used to dilate the cervix and then evacuate the contents of the uterus and then scrape the inner uterine wall to ensure that all products of conception are removed. Now, dilation and curettage has several important complications, and these include infection, bleeding, perforation, and even Asherman syndrome. The first three complications should make sense given that sharp surgical tools are used within the uterine cavity. And that last complication, Asherman syndrome, is discussed in our following lecture titled Follow-up Care of Pregnancy Termination. Next, let's discuss manual vacuum aspiration, which is a procedure that may be performed up to 12 weeks of gestation. So again, we're just thinking the first trimester here. And here's how this works in essence. The clinician will place a cannula into the cervical os and then extracts the uterine contents using a vacuurette. Unlike dilation and curettage, manual vacuum aspiration doesn't involve any curettage. So there really isn't that scraping like we discussed with DNC. Now here's an image depicting the basic premise of a manual vacuum aspiration. Now just to get you oriented with the labels, 1 is the amniotic sac, 2 is the embryo, 3 is the uterine lining, 4 is the speculum, and 5 is the vacuurette, and 6 would be a point of attachment for a suction pump. Now as mentioned on the previous slide, all products of conception are evacuated out of the uterus through the vacuurette. So again, there's no need for that sharp curettage. Unlike the prior two methods, medication abortion is non-surgical, and it's actually best if it's performed before week 7 because that has the highest success rate. Now, there are 3 main medication options: a combination of mifepristone and misoprostol, which is considered the gold standard, or a combination of methotrexate and misoprostol, or the last option, misoprostol alone. Now, the patient experience with this is actually very similar to a miscarriage. Now, it's important to know the gist of the mechanisms by which these medications terminate a pregnancy. Mifepristone is a progesterone receptor antagonist, and it effectively causes detachment of the embryo from the uterine wall. And methotrexate is a dihydrofolate reductase inhibitor that terminates a pregnancy by disrupting DNA synthesis and inhibiting proliferation of placental villi. Lastly, misoprostol is a prostaglandin analog that ripens the cervix and induces uterine contractions, causing the uterus to expel the products of conception. So taking a step back, it actually makes sense that mifepristone and misoprostol are the gold standard when used together. Mifepristone causes detachment of the embryo, and then misoprostol expels it. This table summarizes the most important contraindications to medication abortion. Let's go through each contraindication one by one to understand why it's listed in this table. An ectopic pregnancy is unlikely to be terminated by mifepristone and misoprostol, and it has its own treatment recommendations. And that makes sense, because mifepristone and misoprostol work on the uterus, and if the pregnancy is not in the uterus, then you wouldn't expect these to be effective. Next, an allergy to any of the abortifacient, for example mifepristone, should be an intuitive contraindication to using either one. Now, a patient with a bleeding disorder, such as hemophilia, may actually lose too much blood secondary to this medication abortion. So you're going to want to control the abortion more manually with an invasive procedure, and not just put the patient on medication and hope that they don't bleed out. You're going to want to be there and controlling it. Now, cervical stenosis or obstruction can prevent a complete expulsion of all products of conception, and that can lead to an incomplete abortion, and that can be dangerous. Another contraindication is gestational trophoblastic disease, for example, a hydatidiform mole. This is a tumor-like growth, and it warrants a lot more attention and care in removal than can be expected of a medical abortion, because here you're potentially dealing with cancer, and you don't want to just rely on medications expelling the cancer. You want to be more careful with this. So don't use medication abortion if you're thinking it's a gestational trophoblastic disease. Now, the next contraindication is also fairly intuitive. This is an intrauterine device. So if this is still in the patient's uterus, then when the medication abortion causes those significant uterine contractions, then that device can actually cause uterine perforation, which kind of makes sense. You've got this device inside the uterus contracts around it and pokes a hole in itself. So any intrauterine device should always be removed prior to attempting a medication abortion. Lastly, mifepristone specifically has two additional contraindications. These are chronic steroid use, for example, a patient with Crohn's disease. The second is chronic adrenal failure, which can be seen in patients with Addison's disease. But why is mifepristone contraindicated with these two conditions? Well, it's because in addition to being a progesterone receptor antagonist, mifepristone is also a glucocorticoid receptor antagonist. This means that it interferes with the endogenous mechanisms that control cortisol secretion, and that can pose significant harm to patients on chronic steroids or patients with adrenal failure. And that makes sense, because if they're on those drugs or they're not producing enough cortisol, then that's already dangerous. And then you add this medication, mifepristone, that blocks the receptor of cortisol as well. So that can really put the patient in a dangerous situation. So now let's do a quick question. What medication can be used to treat/terminate an early ectopic pregnancy? The correct answer is methotrexate. Now, unlike mifepristone and misoprostol, methotrexate can be used for both medical abortion and for treatment of ectopic pregnancies because it functions by disrupting fetal growth, eventually leading to fetal demise. Mifepristone and misoprostol, on the other hand, work by affecting the environment of the fetus, specifically the uterus and the uterine cavity, instead of affecting the fetus itself. And since an ectopic pregnancy is a pregnancy outside of the uterine cavity, mifepristone and misoprostol are unlikely to affect it. Now, to learn more about the management of an ectopic pregnancy, please refer to our lecture titled Ectopic Pregnancy, and that's also in our obstetrics chapter. Now that we've covered the methods of pregnancy termination in the first trimester, let's cover the methods used in the second trimester, starting with dilation and evacuation. Now, dilation and evacuation is a procedure that may be performed between 14 and 24 weeks of gestation. So again, it's a second trimester method. Just like a dilation and curettage, a DNC, is considered to be the safest method of terminating a first trimester pregnancy, dilation and evacuation is considered to be the safest method of terminating a second trimester pregnancy. In a lot of ways, the procedure is very similar to a DNC. patients are first given prophylactic antibiotics, and then during the procedure, the clinician dilates the cervix to allow sufficient room for evacuation of all the products of conception, and that can be done using suction or forceps. So that's the evacuation idea. Now, importantly, given the more advanced gestational age, a pelvic ultrasound is usually performed at the end of the procedure to rule out any retained products of conception and thus ensure a complete abortion. Now, the potential complications of a dilation and evacuation are similar to complications of a dilation and curettage. These include infection, bleeding, perforation, Asherman syndrome, and then also retained products of conception. Now, importantly, dilation and evacuation does not allow for delivery of an intact fetus, which is a very critical point that should be discussed with each patient prior to scheduling this procedure. Okay, now continuing with methods during the second trimester, another method is using labor medications. So the first line would be mifepristone and misoprostol, which is familiar to us because we discussed that with the first trimester methods. And the second option is misoprostol alone. And then the third option is IV oxytocin. So if you look at this medication abortion here in the second trimester versus a medication abortion in the first trimester, you can see that it's basically the same. First line treatment is the same. It's mifepristone and misoprostol. You also have the option of misoprostol alone, but instead of having methotrexate as an option, you have IV oxytocin as an option. Now, the critical difference between a medical induction of labor and dilation and evacuation is that this medication route actually allows for delivery of an intact fetus. And for that reason, feticidal agents, for example, digoxin, can be used in combination with the aforementioned regimens to prevent a live birth. In other words, if you're worried about the fetus being alive when it comes out, then you prevent that with digoxin, feticidal. The complications associated with a medical induction of labor include infection, bleeding, and retained products of conception. Now, one of the most important steps in follow-up care is to confirm completion of the abortion using either serum or urine beta-HCG measurement, or you can use a pelvic ultrasound. Again, this is done to rule out retained products of conception. Now, once the abortion is confirmed as complete, clinicians should once again offer emotional support and counseling services where appropriate, and they should discuss contraceptive options going forward in order to help prevent future unplanned pregnancies. Now, here's a table summarizing the key points about the first and second trimester abortion methods that we've discussed in this lecture. So this can be really helpful when you're on the wards or when you're preparing for an exam. Just scan through this and even study using this. Now let's wrap up with a board-style question. A 29-year-old G1P0 woman presents to clinic at 20 weeks of gestation to discuss termination of pregnancy. Her past medical history is notable for Addison's disease. She denies tobacco and alcohol use. Blood pressure is 121/76, pulse is 72, and temperature is 36.5 degrees Celsius. Physical examination is notable for a smooth, firm uterus with a fundal height of 21 centimeters. Laboratory evaluation is unremarkable, and a pelvic ultrasound is consistent with a singleton uterine pregnancy. The patient does not express any preferences regarding the approach to termination of pregnancy. Which of the following methods of pregnancy termination should the clinician offer to this patient? A. Mifepristone and misoprostol. B. Manual vacuum aspiration. C. Dilation and evacuation. Or D. Methotrexate. Okay, the correct answer is C, dilation and evacuation. This is a case of a woman presenting to discuss options for termination of pregnancy, which is obvious. But the important thing you need to recognize here is the gestational age. This is 20 weeks, which puts her in the second trimester. And what other thing from her past medical history is super important that can guide treatment? It's the history of Addison's disease. And then as far as the pregnancy itself, we've got a single fetus and the patient doesn't have a preference. Now, giving all of those factors, a dilation and evacuation is the best possible option for this patient, as it is considered the safest method of terminating a second trimester pregnancy. But what about the other options? Well, option A, mifepristone and misoprostol, is a combination of drugs used in a medical induction of labor, which can be appropriate to terminate a second trimester pregnancy. However, recall from this slide that patients with Addison's disease should not be receiving mifepristone, and that's because mifepristone is a glucocorticoid receptor antagonist. And remember, that patient with Addison's disease already has a deficiency in cortisol. So you don't want to go and just block the cortisol receptors because that makes the situation even worse for her. So that's why option A is incorrect. Now, option B, manual vacuum aspiration, is an appropriate method of terminating a first trimester pregnancy, but not a second trimester pregnancy. Now, lastly, option D, methotrexate, is incorrect because methotrexate is used in treatment of ectopic pregnancies, not intrauterine pregnancies. And also, methotrexate isn't used as a primary means of terminating a pregnancy in the second trimester. Remember, methotrexate is really in the first trimester. So again, the correct answer here for this patient in their second trimester and a history of Addison's disease, the correct answer is C, dilation and evacuation.